Well, good afternoon, everyone. Welcome to today's Dairy XNAP webinar. Our topic for today is causes and implications of subclinical hypocalcemia. Our special presenter today is Dr. Jesse Goff. Dr. Goff is well known and respected as a researcher in the field of hypocalcemia. Dr. Goff received his bachelor's degree from Cornell University and then moved on to Iowa State University and received his master's, DBM degree, and PhD degrees.
Thanks, Bob. We've done a lot of work on milk fever, but I think the take-home message these days is that milk fever is rather controllable. I think we're still having a bit of trouble actually controlling hypocalcemia. So I kind of titled this Hypocalcemia, It's Not Just Milk Fever Anymore. One of the things I think we want to talk about is the implications of this hypocalcemia. And when we look at the national herd, and this is work that was done maybe in the year, between the years 1999 and 2001, a survey of over 2,000 blood samples from farms all over the United States suggested as many as 50% of the older cows fell into this category of being subclinically hypocalcemic. At that point, the cutoff number we were using was 8 milligrams of calcium per deciliter of blood. As Dr. Etzel will no doubt cover in December, there's a lot of conversation now about whether that is the correct cutoff point. Based on a lot of work that Jose Santos has done at Florida, it would look like maybe 8.5 should have been a better cutoff point for these animals, or 8.6 even. I'm not here to debate where the cutoff number should be. My own thoughts are that 8.6 is almost an unattainable number for most farmers, and I kind of settle for these numbers that we used in the past, closer to 8. So the surprising thing about this study when we did it was that as many as 25% of heifers were even included in this subclinical milk fever type zone. We all expected to see a certain number of animals with milk fever, and remember back in the year 2001, anionic salts were still relatively unused, and so I think some of these numbers will probably come down, and I believe probably even the subclinical hypocalcemia is somewhat reduced, but it's still quite prevalent, unfortunately. So what do I care about subclinical hypocalcemia? The animals look pretty normal. It's pretty hard to pick them out of a herd. Well, in those same 2,000 blood samples that we took in 2001, we measured non-esterified fatty acid levels in the blood. And NEFA levels should be an indication of how much body fat is mobilized at a given instant in time. And it didn't matter whether cows were in the first, second, or third lactation. If their blood calcium fell below 8 milligrams per deciliter around the time of calving, they were going to have higher NEFA levels. And it sort of makes sense because we believe hypocalcemia is a great risk factor for a number of disorders of cows. That's kind of summarized in this very busy slide. And I've put hypocalcemia over here on the right-hand side as one of the leading factors that seems to cause a lot of metabolic problems for cows. There's 3 basic factors that I think if we could get a hold of them and control them, we'd do a great deal for our cows. One is immune suppression. So whether or not the animal is immune suppressed, whether or not they have negative energy and protein balance, this often revolves around dry matter intake around calving. And the final one is hypocalcemia. And we're going to spend a bit of time today talking about hypocalcemia and what it does. We know that hypocalcemia directly affects the immune cells. Studies that we've done in our lab over the past few years have shown that these animals are not able to respond to antigens, bacterial cell walls, the way they ordinarily would when the animal's normocalcemic. It appears that this is actually due to a depletion of intracellular calcium within the lymphocytes and neutrophils. Another factor is that hypercalcemia reduces muscle tone, and that may have a direct effect on things like mastitis, failure to close the end of the teat sphincter. That muscle tone also affects the ability of the animal to contract the abomasum, so you see more displaced abomasum. You obviously can get true milk fever or even hypocalcemia affecting dry matter intake in these animals, which exacerbates negative energy balance. And we know negative energy balance is also a factor affecting immunity. You can see that this goes on and on. All these diseases are interrelated, but one of the major factors is hypocalcemia. It's kind of a gateway disease, sort of like when you start becoming hypocalcemic, you can expect to see many other diseases follow. So let's talk about what blood calcium concentration is, what it means to the cow in terms of overall calcium balance. So typically, we think that a cow should have a blood calcium concentration somewhere around 9 to 10 milligrams per 100 milliliters of serum or plasma. Pretty standard number for cows. Where the cutoff should be for hypocalcemia is another discussion. I'll let Gary Etzel handle that next time. If we were to look at a big Holstein cow and we've multiplied this concentration of calcium by the amount of serum in her body, we would find that a typical Holstein cow only has about 3.5 grams of calcium in all of her serum. If we extend that to include all of the extracellular fluids, all the fluids surrounding all the cells of the body, we now increase that to about 11 grams of calcium. Now, normally, you would expect there to be a certain amount of loss of calcium every day. There's a certain amount that's going to be excreted out through the feces. These represent pancreatic secretions, intestinal secretions that just are not recovered, so calcium can go out into the feces every day, and that amounts to maybe 5 or 8 grams of calcium. The second factor is how much goes out through the urine every day. And this one is kind of a strange one. We'll spend a little time on this. Ordinarily, cows that are on no anionic salts will excrete somewhere between 0.2 and 0.5 grams of calcium per day in the urine. Not very much at all. When you put them on anionic salts and you acidify their blood, we can kick this number up close to 6 grams of calcium per day going out in the urine. Now, I've got a little star here because we'll talk about the role of PTH, parathyroid hormone, in a few minutes. There's some question about whether or not the cow on an anionic diet can recover a good amount of this 6 grams of calcium and use it to help her balance her calcium at the time of calving. Well, obviously, the big problem with milk fever is that these cows begin to lactate. And when they begin lactation, they start losing a lot of calcium out of this serum and extracellular fluids. As much as 20 to 30 grams of calcium per day can be lost from these fluids. So if you just do the math, you can see if I'm losing 30 grams of calcium a day, I'm expected to turn over my serum pool somewhere close to 8 or 9 times in a single day to make that milk. That's a huge physiological feat. Well, how are we going to do that? Well, we can bring calcium back into the extracellular fluids by utilizing bone calcium. Bones have a tremendous amount of calcium stored in them. If we can liberate that calcium, send it to the extracellular fluids, the serum, we can help keep blood calcium normal. So when we look at a bone, all the bone skeleton of a cow, there's typically somewhere close to 8 kilograms of calcium. That's 8,000 grams of calcium that could potentially be drawn from that skeleton. I don't know that we want to recommend you pull a lot of it out because you do need a skeleton to allow you to stand, but certainly the skeleton can lose a certain amount of calcium. We have done calculations in the past suggesting that cows lose somewhere between 10 and 13 skeletal calcium in early lactation. Another source of calcium is this so-called bone fluid calcium. It's only a small amount of calcium, maybe 9 to 15 grams of calcium per day, and we'll talk about where that is and how it's liberated. The number 9 is probably the number that we're going to see in a cow who's not on anionic salts. It turns out when you put them on anionic salts, this number jumps up by 5 to 7 grams of calcium per day. Well, what controls liberation of calcium out of bone? It's this hormone called parathyroid hormone. And in the neck of the cow, just as in your neck, there's a couple of little glands that are very sensitive to any kind of change in blood calcium concentration. There's a little branch of the carotid artery runs through there. If blood calcium falls below 9, or whatever the animal considers to be normal, you're going to see a tremendous increase in parathyroid hormone secretion. Now, parathyroid hormone will act in two ways. It will stimulate release of calcium from this bone fluid back into the extracellular pool, or it will stimulate the release of calcium that's tightly held in bone crystals back into the serum and extracellular fluid pool. Let's take a look at a piece of bone. This is a typical bone. It'll have compact bone on the edges here and trabecular or spongy bone in the middle. This spongy bone is the one that's most likely to be affected by parathyroid hormone and is the one that contributes most of the calcium when we're talking about calcium homeostasis. Here we've got a small little piece of bone under the microscope, and we'll label the cells here. These are osteoblasts that line this bone. We've got a couple of huge cells called osteoclasts. Out here we've got the bone marrow cavity, which is essentially the bloodstream. And then we've got various types of osteocytes here. And hopefully you can see around each osteocyte there's a little bit of a fluid space. All right, the first type of resorption of bone calcium occurs as a result of parathyroid hormone stimulating these osteoclasts. Under the influence of parathyroid hormone, these cells start digging a divot, and you can kind of see a divot being dug out of the bone right here, and that will release the calcium and phosphorus back into the bloodstream. This process is not necessarily very fast. Probably takes 2 days to begin this process and make it a significant contributor to bone calcium. But over the course of early lactation, this process will probably result in liberation of 700 to 1,000 grams of calcium out of a typical cow's skeleton. The next portion of the bone contribution to this extracellular calcium pool comes from the bone fluids. And if we look at these osteocytes, each one of them is surrounded by a little tiny bit of fluid, and in that fluid is a very high concentration of calcium. And all these bone cells are connected to one another by a canalicular system, or in other words, a series of canals. And all those canals eventually lead back to a central vein. And that would bring the calcium from these bone fluid areas back into the central vein. So when stimulated by parathyroid hormone, these osteocytes can actually pump that calcium back into the bloodstream. It's only a small amount of calcium, maybe as much as 15 grams in a cow on anionic salts, maybe only 9 grams in a cow that's not on anionic salts. But that's going to be a fairly rapid response, and perhaps it's important that first 24 hours after calving, when hypocalcemia is so rampant. So we've got the bone situation covered here. Now we're going to worry about the diet, because ultimately we want to use diet calcium to help restore these extracellular fluid pools. The first type of calcium absorption across the gut is a passive calcium transport. This really only works when the diet calcium is quite high, somewhere above 100 grams of calcium per day. We can expect a good amount, maybe 20, 30, 40% of the calcium that the animal needs will be absorbed by passive calcium transport. The way this works is you get very high amounts of ionized calcium, in other words, soluble calcium, in the lumen of the gut. Here we've got a couple of little intestinal epithelial cells. They've got a tight junction between them, separating the cells. Here's another tight junction. Under the influence of this very high ionized calcium, the calcium can actually cross the tight junction and move directly into the bloodstream of the animal. This sort of passive transport of calcium will only work if diet calcium is very high and if the calcium in the diet is very soluble. You may be more familiar with this idea in terms of using calcium gels, calcium pastes, drenching cows, and you need a very soluble form of calcium, such as calcium chloride, calcium sulfate in some cases, to get this done. Calcium carbonate, limestone will not work this way. Well, in most animals, you can't rely on all of your calcium coming from this passive transport. So there's a second mechanism that's involved in getting calcium absorbed across the GI tract, and it's an active calcium transport. Active implies that it takes some energy from the animal to get this accomplished. And this process is under the control of a hormone called 1,25-dihydroxyvitamin D. It's the active hormonal form of vitamin D. Now, to make 125 vitamin D, the kidney has to take 25-hydroxyvitamin D and convert it into 125 vitamin D. And it will only do that under the influence of parathyroid hormone. We'll look at that a little differently here. You can have vitamin D coming in from your diet, or theoretically, the cow is capable of converting 70-hydrocholesterol to vitamin D within its skin if you have ultraviolet irradiation of the skin. Most of our cattle probably aren't spending enough time out in the sunlight to actually get this done, so we feed them vitamin D. The vitamin D is converted in the liver to 25-hydroxyvitamin D, still has no biological activity until it goes to the kidney. And if the kidney has been properly stimulated by parathyroid hormone, it causes the production of this hormone, 125-dihydroxyvitamin D. What 125-dihydroxyvitamin D does is it arrives in the bloodstream from the kidney, heads to the intestinal epithelial cells, and will bind to a receptor inside those cells. And once that receptor binds, it causes transcription and translation of a couple of proteins. And the three proteins you get are TRPV6, calcium binding protein, and a calcium pump. Now the TRPV6 lets calcium come across the first membrane of the intestinal cells, where that calcium is picked up by the second protein called the calcium binding protein. That calcium binding protein then carries the calcium to the calcium pump, and the pump will then push that calcium out of the cell into the bloodstream. This process is very, very efficient at utilizing low dietary calcium. It's critical for the cow to have this activated if she's going to make good use of dietary calcium. That's why vitamin D is so important in their diet and why activation of that vitamin D to the hormonal form is so critical. Without these proteins, the calcium pump, the calcium binding protein, TRPV6, no calcium gets absorbed by this method. You're totally relying on passive transport, and that just isn't adequate. So we've got this system now that ordinarily works quite well in most cows. It centers on parathyroid hormone, stimulating kidney to produce another hormone that's going to stimulate active transport of calcium. The parathyroid hormone can stimulate by two different mechanisms. removal of calcium from the skeleton and put it back into this extracellular fluid. And all this is going to be done to help support this cow in lactation. Hopefully, at some point, she's going to be eating enough feed that's high enough in calcium that all of her needs can be met through the diet, and she'll stop pulling calcium out of her bones. But in early lactation, all cows have to pull calcium out of their bones. Well, parathyroid hormone is the key hormone here, and it works by binding to a little receptor on the bone and on the kidney cells. And when parathyroid hormone is released, and I've kind of schematically put it here, and we've got a normal blood pH and normal amounts of magnesium in the blood, the parathyroid hormone has a nice lock and key fit with its receptor. That activates this adenyl cyclase enzyme. It produces cyclic AMP inside the cells, and that turns on the bone cells. We get calcium out of the skeleton. It turns on the kidney cells. They make 125 vitamin D. They resorb more calcium from the urine. Everything's hunky-dory. The cow doesn't get milk fever, doesn't get hypocalcemia for very long. It quickly recovers from the insult of onset of lactation. Unfortunately, many of our cows are fed relatively high potassium diets. Their blood pH tends to be somewhat alkaline, and as a result, the receptor for parathyroid hormone takes on a strange shape. Now when parathyroid hormone is released, it no longer binds to its receptor, doesn't activate this enzyme to make cyclic AMP. The animal is surrounded by tons of parathyroid hormone. We can measure bucket loads of it in the blood, but it's inactive in the animal because the receptor is no longer properly shaped. Turns out this is purely a function of acid-base physiology. Alkalosis, the animal has a poor receptor. Acidosis, the receptor works just fine. Well, we can also have another situation where the animal is acidotic or in good shape with metabolic acidosis. And unfortunately, we're in a situation of hypomagnesemia. And if you looked carefully at this cartoon, there's a magnesium atom sitting here. Without that magnesium atom, we can have parathyroid hormone released. It can bind to its receptor, but the lack of magnesium still prevents the cyclic AMP from being made. Again, the tissues will not respond to parathyroid hormone. You get milk fever. Well, there's various ways to acidify cows. I'll spend a few minutes talking about some of the better ways to do this. Some people have looked at DCAT equations and thought sulfur should be a good ingredient to acidify a cow. If we use urine pH as a good indicator of what blood pH should be, and which it typically is, it usually reflects blood pH quite nicely. Much easier to measure urine pH than it is blood pH. So we've tried to put this in terms of urine pH. Elemental sulfur will not change urine pH. Mag sulfate, calcium sulfate, reduce it somewhat. Sulfuric acid, again, reduces it somewhat. It's the chloride salts that seem to be the most active, and the most active of all of those is hydrochloric acid. So the more powerful anionic salts tend to be chloride-based, although sulfate salts will work to some extent. The chloride salts tend to be the more useful. Hydrochloric acid in our hands turned out to be the most palatable of the anionic salts too. So today there are many commercial products on the market that actually incorporate the best of these ideas to produce products that are palatable. The problem with the traditional anionic salts, throwing calcium chloride in the diet or ammonium chloride in the diet, mag sulfate in the diet, these traditional anionic salts were plagued with poor intake on the cows, which ended up causing more trouble than it fixed. So this is kind of a screen that would give you an idea of where your mineral levels should be in these animals if you're looking at close-up cow diets. Phosphorus should be kept at about 0.3, 0.37%. Magnesium at about 0.4%, and we'll talk a little bit more about that. Sulfur, meet the needs of the cow, which is about 0.22%, and try not to go too much above 0.4%, because there are some problems with sulfur toxicity in some situations. Calcium, I put 0.85 to 1.3% for no really good reason. Our research suggests that it's not that critical a number. Sodium, just meet the animal's needs. Never give them more salt than they need because you'll contribute to udder edema as well as acting as a positively charged cation that will alkalinize the cow. And then try to keep potassium as close to 1% as possible, which is the true trick of feeding these cows. And then bring in enough chloride to drop their urine pH. So, if all you want to do is stop milk fever, just keep your diet sodium at about 0.1% and keep diet potassium down to about 1%. And milk fever, the clinical milk fevers, will pretty well go away in Holsteins. If you really want to attack this subclinical hypocalcemia, you're probably going to have to add anions, and I choose to usually use chloride as the basis of my anion program. How much chloride should you add? Enough to bring the urine pH between about 6.2 and 6.8 a week or so before calving. For Jerseys, we might go a little bit lower than that because they seem to take a little bit more effort to really control hypocalcemia. If you drop the urine pH below 5.3, you will have caused an uncompensated metabolic acidosis. Our whole goal in this was to create a compensated metabolic acidosis, so if you do this, you're going to be in trouble. How much chloride should you add? Our thumb rule is percent potassium minus 0.5, and move up from there based on urine pHs. Collecting urine, you can see various scenarios here on how to do that. Scenario 1, the average pH is 6.3, and there's always a variance here. Don't worry about the variance. Go with the average. So 6.3 is the average. That's pretty good shape. Scenario 2, your average 7.4. You're probably needing to add a little more anion. Do it in small increments and give it a week or so to kick in and then check it again. Scenario 3, the average pH was 5.2, plus or minus a half. You're probably too low. Reduce your anions. This is the more problematic situation where you have some cows at 5.2, some at 7.8. It probably means the cows are varying in their intake because of overconsumption of anions. Back it off. But it could also be an indication the cows are sorting your diet, so make sure you check that out as well. So I think we've convinced everybody that you need to look for low potassium hays for cows. But I want to tell you that if you search hard enough, you can also find low potassium, high chloride hays. And if you want to purchase those forages, you're usually better off as a forage for the dry cow. So we talked quite a bit about magnesium being needed to get this whole system going. I want to perhaps end up here because I'm probably running over on time. With the idea that blood magnesium is quite critical to these fresh cows, and we're finding an awful lot of hypomagnesemia in cows. A lot of it is because the magnesium that's fed to cows these days is not very available to the animal. And so we find the post-calving, the problem is magnesium oxide. Pre-calving, if you're using ionic salts, almost all the companies are using nice forms of magnesium that are very available. It's the post-calving that's getting the cows. And that's a little test you can do to check out magnesium oxide availability. Many of the companies selling this don't like this test because many of the magnesium oxides they're selling fail. But I'm going to tell you that this is a very worthwhile test to allow you to meet the magnesium needs of animals. I think I'm going to stop there because I think I'm probably way over on time anyway.
Okay. Here's a question, Dr. Goff, from Donna. It says, can you talk about feeding anionic salts the entire 60-day dry period as opposed to, more traditional 2 to 3 weeks prior to?
Do quite fine. It does change your target. And so we've decided that the best way to decide how much anions you have is to check the urine pH after cows have been on the diet for about 2 to 3 weeks. after that time, their urine pH slowly starts drifting up. But as far as effectiveness, it's just as effective over a 60-day dry period as it is the last 21 days.
We got a few more questions coming in here.
So I'll try to answer this question from Alyssa Hunter. What are your thoughts about using Bovacalc boluses over DCAD for managing hypocalcemia? I would not recommend Bovacalc boluses over a good anionic salt program. However, I think, and I'm sure Gary Etzel will contribute on this next month, there is some evidence that perhaps an anionic salt program isn't enough, that maybe we need to actually throw oral calcium gels, boluses, pastes in on top of this to ensure that the amount of subclinical hypocalcemia is reduced as well. I would not say use Bovacalc in place of an anionic diet. And it'll be interesting to see what Gary says next month, but I would think he's probably agreeing with that.
Okay. Well, thank you very much, Dr. Goff. Thank everybody for participating in the webinar today, and hopefully we'll see you again next month.